Welcome to the History Maps podcast. A peasant in the 9th century has gone blind from cataracts.
Right. A fairly common affliction.
Yeah, and if this person lives in Western Europe at the time, the primary medical intervention available might involve, a local monk praying over the affliction.
Or perhaps an apothecary applying some sort of topical salve that does, well, absolutely nothing.
Exactly. And the general consensus is just that the blindness is a supernatural punishment. You just have to endure it. But if this same peasant walks into the city of Baghdad, the scenario shifts completely.
It's a totally different world.
They're admitted into a sprawling stone complex. They are handed fresh, clean linens. They get assigned a bed in a specialized ophthalmology ward.
Which is highly staffed, yeah.
Right. A dedicated surgeon examines them and uses a custom-designed needle to physically remove the obstruction from their eye.
And then they recover in a room with running water and fresh air.
And when they're finally discharged, the hospital administrators actually hand them a monetary stipend so they don't have to return to manual labor right away. And this entire intervention costs the peasant absolutely nothing.
It's a massive departure from the conventional narrative of the era, The medieval period is frequently characterized as this era of global scientific stagnation.
Right, a time when the human body was treated with superstition.
Yeah, rather than empirical scrutiny. But what you just described is not an anomaly at all. It is the standard operation of an institutionalized public health system.
We are talking about massive secular medical facilities functioning on a scale that closely mirrors modern infrastructure.
Which is exactly the mission for this deep dive.
Yeah, we are going to examine the Islamic medical tradition between the 7th and 16th centuries. Our goal is to understand how these civilizations didn't just preserve ancient Greek or Indian knowledge, but fundamentally re-engineered healthcare.
We need to look at the mechanics of their pharmacology, the specific tools they invented for surgery, and the economic structures that allowed for free universal healthcare a millennium ago.
So to understand the highly organized hospitals of Baghdad or Damascus or Cairo, we have to look at the foundations that preceded them.
Right, because the Islamic medical tradition didn't just emerge out of nowhere. It was the product of a deliberate, highly funded state effort to gather the sum total of human medical knowledge.
And a crucial early incubator for this synthesis was the Academy of Gondishapur.
Yes, Gondishapur.
Which was located in Sassanid Persia, founded back in the 6th century. When you look at the geographic position of the Sassanid Empire, it sat right on the Silk Roads, right?
Functioning as a massive cultural turnstile.
Yeah, you had Greek scholars fleeing persecution in the Byzantine Empire moving east, and Indian Ayurvedic practitioners moving west.
Gondishapur was a place where these disparate traditions actively blended together. I mean, the Greek tradition was highly theoretical, right? Focused on anatomy and philosophical frameworks.
While the Indian tradition was much more practical.
Exactly. The Ayurvedic texts emphasize detailed surgical techniques and botanical remedies. And the Persian physicians themselves were deeply focused on dietetics and pharmacology.
So when the Islamic conquests incorporated the Persian territories in the 7th century, the new rulers didn't dismantle this academy.
No, they recognized the immense value of this intellectual crossroads. They integrated the scholars directly into their burgeoning administrative structures.
Which brings us to the Abbasid Caliphate and the establishment of a huge state-sponsored institution in Baghdad known as the House of Wisdom, or Beit al-Hikmah.
This initiative began under Caliph Harun al-Rashid,
who ruled from 786 to 809.
Right, and it aggressively expanded under Caliph al-Ma'mun, ruling from 813 to 833. They essentially launched what we call the translation movement.
And this was a huge intellectual enterprise. The caliphs and wealthy private patrons poured fortunes into funding scholars to travel, locate, and translate classical treatises.
Moving texts from ancient Greek, Persian, Syriac, and Sanskrit into Arabic. They actively targeted the foundational texts of ancient medicine, specifically the works of Hippocrates, Galen, and Dioscorides.
Let's talk about the mechanics of this translation, because it wasn't just a matter of swapping one word for another. The linguistic puzzle here is pretty complex.
Oh, absolutely.
You have Greek medical text filled with highly specific anatomical terminology, and the translators are moving this into Arabic, a language that, at the time, just didn't have the vocabulary for those concepts.
And one of the most prominent figures navigating this was Hunayn ibn Ishaq, a Nestorian Christian.
His methodology was exceptionally rigorous, wasn't it?
It was. He didn't simply locate a single Greek manuscript and translate it directly. He understood that these texts had been copied by hand for centuries, accumulating errors with every generation.
So he actively collated multiple Greek manuscripts of the same text.
Right, cross-referencing them to resolve discrepancies and identify scribal errors. He was establishing what we would call a critical edition of the text today. Only then did he begin the translation process.
And he translated over 129 of Galen's works. But often he translated them first into Syriac, his native language, and then into Arabic. Why take that intermediate step?
Well, Syriac, which is a dialect of Aramaic, had already absorbed a significant amount of Greek philosophical and scientific terminology over the preceding centuries.
Because of its use by Eastern Christian scholars.
Exactly. It served as a linguistic bridge. When Hunayn finally moved the text into Arabic, he often had to invent entirely new Arabic words to accurately convey complex anatomical structures.
He was systematically constructing a precise Arabic medical vocabulary.
Yes, one that allowed for exact transmission of data.
The records from this period show it wasn't just Greek texts either. Around the year 800, a massive Sanskrit text, the Sushruta Samhita, was translated into Arabic as the Kitab Shashun al-Hindi.
And that brought Indian surgical techniques, which were far more advanced in physical interventions than the Greek traditions, into the dialogue.
It also introduced the Ayurvedic Trinosha theory, right? The balance of wind, bile, and phlegm.
Right. And the sheer scale and funding of this operation cannot be overstated. Translators like Hunayn ibn Ishaq were compensated enormously,
Sometimes receiving the physical weight of the translated books in gold.
which achieved something really important. It established Arabic as the universal language of science.
Prior to this, knowledge was siloed by language.
Exactly. A scholar in Spain could not read a text from India. But once everything was translated into Arabic, a physician in Cordoba, Spain, was reading the exact same standardized Galenic text as a physician in Samarkand.
I look at the House of Wisdom and the translation movement, and it functions very much like a medieval open-source software project.
That's a good way to look at it.
You have all this disparate localized data from Greece, India, and Persia. The House of Wisdom standardizes it all into a single coding language, Arabic.
And once it is in that universal language, any physician across the vast empire can access the code, test it, debug it, and upgrade it.
Yeah. It was a process of active synthesis, not passive archiving.
We see this clearly in the work of a scholar named Ali ibn Sal Rabban al-Tabari. Around the year 850, he authored an encyclopedia titled the Firdaus al-Hikmah, or the Paradise of Wisdom.
He didn't merely list Greek concepts in Chapter 1 and Indian concepts in Chapter 2.
No, he actively integrated them. He took Persian dietary regimens, Indian surgical practices, and Syrian pharmacological compounding, and synthesized them into a unified, highly practical guide for practicing physicians.
So by the 9th century, they have gathered, translated, and synthesized this vast repository of global knowledge. But how did these medieval practitioners actually view the human body?
That's the key question.
If you walk into a clinic in Baghdad in the year 850, what is the underlying biological framework the physician is using to diagnose you?
The dominant physiological framework they utilized was humoral theory, inherited largely from the Greeks, specifically Galen.
And subsequently refined by Islamic physicians.
Right. The foundational premise of humoral theory is that human health is dictated entirely by the precise balance of 4 vital fluids, or humors, circulating within the body.
Blood, yellow bile, black bile, and phlegm.
Exactly. And these humors were mapped to the 4 elements and specific physical qualities.
Blood was hot and wet, like air. Yellow bile was hot and dry, like fire. Black bile was cold and dry, like earth. And phlegm was cold and wet, like water.
Health was defined as a state of equilibrium among these 4 fluids, a state known as eucrasia. Disease, conversely, was defined as dyscrasia, an imbalance.
So if a patient presented with a fever, the physician diagnosed this as an excess of yellow bile, which is hot and dry.
And the treatment is entirely logical within that framework. You prescribe foods, medicines, or environmental changes that possess cold and wet qualities to counteract the heat and dryness.
Bringing the humors back into balance.
Right. And this theoretical framework operated alongside the principles of prophetic medicine, or Tibbun Nabawi.
Islamic teachings placed a heavy emphasis on the duty to seek medical treatment. This was rooted in specific sayings of the Prophet Muhammad, the hadiths, with the most central statement being, God has sent down the disease and the cure.
That specific theological position provided a direct mandate for empirical science. It establishes that illness is not some mysterious divine punishment to just be endured through prayer.
Illness is a physical state of the body.
Yes. And the divine has provided a physical, tangible remedy in the natural world. Therefore, it's the religious duty of the physician to meticulously study the natural world, test botanicals, and observe the body to discover that cure.
This religious mandate drove the development of intense diagnostic techniques. You have to figure out exactly which humor is out of balance. And the primary methods for this were uroscopy, the visual examination of urine, and sphygmology, the taking of the pulse.
Let's look at the mechanics of uroscopy first.
All right. The famous physician Avicenna, in his Canon of Medicine, didn't just look to see if urine was dark or light. He classified 23 distinct types of urine based on variables like color, consistency, the presence of sediment, and smell.
And taste. The observation was entirely sensory.
Wait, hold on. Taste. Are you telling me these highly compensated physicians in Baghdad were actively drinking their patients' urine to diagnose them?
Well, they were either directly tasting it or they were utilizing a slightly less visceral method.
Which was?
Pouring the patient's urine onto the ground and observing if ants were attracted to it.
Okay, that makes sense. Both methods were utilized to detect the presence of severe sweetness in the urine,
Which indicates the presence of excess sugar. They were physically diagnosing glycosuria.
excessive clear urine that tasted sweet or attracted insects was identified and formally documented as a key indicator of diabetes.
They were accurately mapping physical symptoms to specific systemic diseases.
And the pulse reading, or sphygmology, was just as mechanically complex. Today, a doctor puts 2 fingers on your wrist and checks a watch to see your heart rate. But how did a medieval doctor measure the precise rhythm and rate of a pulse without a modern timepiece?
The Islamic physicians utilized an intricate framework of 10 specific parameters to evaluate the pulse. They didn't merely count beats.
They analyzed the expansion and contraction of the artery.
Yes, they measured the amount of the pulse, meaning the length, breadth, and depth of the arterial expansion. They measured the strength of the strike against their fingers.
They measured the duration of the movement, the duration of the rest period between beats.
The compressibility of the artery and the temperature of the skin over the pulse point.
But without a watch, how did they quantify the rhythm?
They mapped the rhythms of the pulse to the established meters of Arabic poetry and music.
Oh, that's interesting.
Yeah, a physician trained in the complex metrical structures of poetry could feel the arterial rhythm and categorize it as a specific poetic meter, noting if the beats fell on the primary or secondary stresses.
And by feeling these minute variations, they diagnosed internal inflammations, the specific stages of various fevers, and even profound emotional disturbances.
Exactly.
But I have to push back here for a second. We are detailing this incredibly complex system of categorizing urine and mapping pulses to poetry. But their entire understanding of cellular biology was based on an objectively incorrect theory.
The humoral theory.
Right. The human body is not governed by 4 humors. If their foundational premise is a biological fiction, wasn't their entire medical practice essentially a dead end?
That's a very logical assumption to make from a modern perspective. However, the historical reality is quite the opposite.
How so?
Well, while the underlying cellular theory of the 4 humors was objectively flawed, the methodology that the theory demanded was highly rigorous and practically effective. Humoral theory demanded intense, systematic observation of the patient.
Because you can't just prescribe a standard pill. You have to figure out a specific individual's unique humoral makeup.
Precisely. To determine a patient's humoral balance, a physician had to meticulously track their daily diet, the climate they lived in, their sleep patterns, their emotional state, and the daily changes in their bodily fluids.
This relentless focus on data collection accidentally forced them to invent excellent clinical observation habits.
Yes. They were essentially compiling detailed patient dossier. They were cataloging exactly how specific dietary changes, environmental adjustments, and herbal compounds altered a patient's physical state over weeks and months.
They were practicing highly effective evidence-based symptom management.
They lacked the microscopes to see the bacteria causing an infection, sure, but through rigorous observation, they figured out exactly which cooling botanical compound reduced the fever caused by that invisible bacteria.
Right, and this rigorous culture of clinical observation produced specific physicians who took the translated ancient texts, tested them against real patients in the massive hospitals, and thoroughly documented the results.
2 absolute giants of internal medicine emerged during this period, Al-Razi and Avicenna.
Muhammad ibn Zakaria Al-Razi, known in the Latin West as Rhazes, lived from 865 to 925. He was a Persian physician who served as the chief director of hospitals in both the city of Ray and the capital, Baghdad.
Al-Razi was fundamentally an empiricist. His entire methodology was grounded in hands-on clinical trials.
There's a historical vignette regarding Al-Razi that illustrates his approach well. When the caliph asked him to select the site for a new hospital in Baghdad, Al-Razi didn't just guess, and he didn't pick the most politically convenient plot of land.
He went to the butcher's and ordered fresh pieces of meat.
Right. He hung these pieces of meat on poles in various neighborhoods across the entire city of Baghdad.
And Baghdad is situated on the Tigris River, with a complex climate of intense heat, specific wind patterns, and varying levels of urban density.
Exactly. Al-Razi monitored the meat over several days. He then built the hospital at the specific location where the meat decayed the slowest.
He reasoned that the area where the putrefaction was most delayed possessed the cleanest air, the most favorable wind patterns, and therefore the healthiest environment for patients recovering from surgery or infectious diseases.
It's a textbook demonstration of environmental testing. You assess the variables before committing the resources.
And Al-Razi documented his extensive clinical experience in a massive 20-volume work called the Kitab al-Hawi, or the Comprehensive Book of Medicine.
This wasn't a polished theoretical textbook, was it?
No, it was a raw, highly detailed collection of his daily clinical notes, patient case studies, and observations of what worked and what failed.
One of his most notable clinical achievements was the first definitive differentiation between smallpox and measles.
Right. Before his treatise on the subject, physicians often confuse the two as varying severities of the same ailment.
But Al-Razi engaged in a huge epistemological shift. He didn't just look at the rashes. He used inductive reasoning to chart the entire course of the diseases over time.
He meticulously documented the distinct morphological patterns of the rashes. He noted the entirely different incubation periods. He recorded the varying severity and timing of the associated fevers.
And by charting the temporal progression of hundreds of cases, he proved they were two distinct pathologies requiring different treatment protocols.
He also pioneered what we would recognize today as early clinical trial methodologies. When testing the efficacy of a newly compounded drug, Al-Razi documented a strict protocol.
You test the compound on animals first. If it's safe, you administer it to healthy human volunteers to observe any toxic side effects.
Only after it passes those stages do you administer it to the sick. Furthermore, he established dedicated psychiatric wards in the hospitals he directed,
Formally recognizing the psychosomatic connections between mental distress and physical pathology.
Yes. Now, if Al-Razi represents the ultimate hands-on clinical practitioner, then Avicenna, or Ibn Sina, represents the grand architect of medical theory.
Avicenna lived from 980 to 1037, and his most significant contribution was the Canon of Medicine, completed around 1025.
To call the canon an encyclopedia feels almost insufficient. It is a massive, million-word, 5-volume text that systematically organized the entirety of known medical knowledge.
Greek, Roman, Indian, Persian, and Arabic.
All of it into one cohesive, highly logical structure. It was divided into specific books covering general medical principles, materia medica, diseases specific to individual organs from head to toe, systemic diseases like fevers that affect the whole body, and the compounding of complex drugs.
Avicenna systematized pharmacology within the canon, listing and detailing the properties, dosages, and contraindications of over 700 different drugs.
He also advanced the understanding of epidemiology. He correctly identified the contagious nature of infectious diseases, understanding that certain pathogens could spread from person to person through the medium of air or contaminated water.
He was a philosopher as well as a physician. He extensively explored the nature of the mind and neurology. He was the first to categorize human senses into a highly structured framework.
Dividing them into 5 external senses.
Hearing, sight, smell, taste, and touch.
And 5 internal senses, which he defined as common sense, imagination, instinct, and intentions, mapping these cognitive functions to different theoretical regions of the brain.
The contrast in their methodologies is stark but really complementary. Al-Razi is in the wards, aggressively tracking trial and error data and building a repository of clinical evidence.
While Avicenna takes that massive repository of evidence and organizes it into a highly digestible, intensely structured curriculum that can be standardized and taught in medical schools across the world.
But I want to revisit Al-Razi for a moment because this touches on a crucial transition in the history of science. We established that the entire Islamic medical tradition was built on translating and respecting the ancient Greek authorities like Galen. But did these empirical practitioners ever reach a point where their clinical data contradicted the ancient texts?
Yeah.
Did Al-Razi ever explicitly reject Galen?
He did, actually, and he did so in formal writing. Al-Razi authored a specific treatise provocatively titled Doubts About Galen.
So he didn't hold back.
Not at all. In this work, he relied entirely on his own empirical data, gathered meticulously from his patients in the Baghdad hospitals, to openly challenge and correct several of Galen's long-standing assumptions about humoral pathology and fever management.
He explicitly stated that while Galen was a pioneer worthy of respect, his theoretical deductions did not always align with the empirical reality observed at the patient's bedside.
That is a massive paradigm shift. It is the defining moment where empirical data gathered through observation explicitly supersedes ancient established authority.
So Al-Razi and Avicenna essentially perfected the software of medicine, right? Diagnostics, clinical trials, internal humoral management, and pharmacology.
Correct.
But what happens when the hardware breaks? When a patient has a massive bladder stone or a clouded cataract, dietary adjustments and cooling herbs will not save them. Physicians had to physically cut into the human body.
And that requires a completely different type of intervention. This transition from internal medicine to physical intervention brings us to Al-Zahrawi, known in the Latin translations as Albucasis.
He lived from 936 to 1013 and operated primarily in Cordoba, located in Andalusia, which is modern-day Spain.
He is widely recognized as the father of modern surgery.
Al-Zahrawi authored a huge 30-volume medical encyclopedia called the Kitab al-Tasrif, but it's the final volume of this work that is truly notable.
It was a comprehensive, heavily illustrated manual dedicated entirely to surgery and surgical instruments. He didn't just describe the procedures, he invented and illustrated over 200 specific surgical tools.
The visual element of the Kitab al-Tasrif was unprecedented. He provided highly detailed scaled drawings of scalpels, bone saws, retractors, specula, curettes, and obstetrical forceps.
He specified exactly what metals the tools should be forged from, the precise anatomical angles for the blades, and the exact physical mechanics of how the surgeon should hold and maneuver them during an operation.
When you look at the illustrations, it reads exactly like a modern surgical supply catalog. If he encountered a complex surgical problem, such as a difficult breech delivery or a deeply embedded arrow, he didn't just invent a new hand maneuver.
He went to the forge and engineered the exact specialized metallic tool required to execute the extraction safely. His focus was relentlessly practical, driven by a need to reduce mortality in the operating room.
One of his most enduring material innovations was the introduction of catgut for internal sutures.
Yes. Prior to this, surgeons often used materials like silk or heavy thread to stitch internal tissues. The body does not absorb these materials, which meant the sutures would invariably cause severe internal infections or require painful secondary surgeries to remove.
How did the catgut solve this?
Catgut is actually made from the intestines of sheep or goats. Because it is a natural collagen, Al-Zahrawi realized that if he used it to stitch internal organs or muscles, the body's natural enzymes would safely break down and absorb the sutures over time.
Long after the wound had firmly healed.
Exactly. It eliminated the source of internal festering, and it is a material concept still utilized in modern surgical suites today.
But if you are going to physically cut into someone, particularly for deep internal operations, you are facing two massive hurdles: agony and putrefaction. Without modern anesthetics or antibiotics, how do they keep patients from going into shock, and how do they stop the incisions from becoming infected?
To manage the pain of surgery, Islamic surgeons utilized the soporific sponge. This was a highly engineered delivery mechanism for anesthesia.
They would take a sea sponge and soak it in a potent, carefully measured aqueous mixture of narcotics.
Primarily opium, mandrake, hemlock, and hashish. The sponge was then left to dry completely in the sun.
So they essentially created a stable, storable anesthetic cartridge.
Exactly. When it was time to operate, the surgeon would take the dried sponge, moisten it with warm water or light wine to reactivate the compounds, and place it firmly over the patient's nose and mouth.
The active narcotic alkaloids were absorbed directly through the mucous membranes and the respiratory tract,
inducing a deep state of inhalational anesthesia, rendering the patient completely unconscious and unresponsive to the pain of the scalpel.
And once the patient is unconscious, how do they address the risk of infection? This is centuries before germ theory.
Long before the discovery of microscopic bacteria, Al-Zahrawi pioneered rigorous methods of antisepsis based entirely on empirical observation. He noted that certain liquids prevented the putrefaction of organic matter.
Therefore, he insisted on aggressively cleansing the patient's wounds, as well as thoroughly washing his surgical instruments with distilled alcohol extracted from wine and with highly acidic vinegar solutions.
He recognized that this chemical intervention halted tissue decay and promoted clean healing.
Because he successfully controlled the variables of pain and infection, Al-Zahrawi was able to perform complex, invasive procedures that were previously considered unsurvivable.
The records show him performing tonsillectomies using a specialized guillotine tool he designed to quickly sever and retrieve the tissue.
He performed complex lithotomies, which is the agonizing process of surgically cutting into the perineum to remove massive stones from the bladder, and he performed cataract couching.
Cataract couching is a highly delicate procedure requiring immense physical precision.
Walk us through the physical mechanics of that. How exactly did they restore vision to a clouded eye?
Well, the surgeon would use a specialized, extremely fine needle invented for this purpose. The patient is restrained. The surgeon inserts the needle directly through the sclera.
The white outer layer of the eyeball?
Right. They then carefully navigate the needle behind the iris to physically engage the opaque, clouded lens. The surgeon uses the needle to forcefully break the delicate zonular fibers holding the lens in place.
And then pushes the entire clouded lens down into the vitreous cavity at the back of the eye.
Yes.
That sounds absolutely terrifying.
It was a brutal mechanical intervention, no doubt, but by pushing the opaque obstruction out of the visual axis, light could once again strike the retina, immediately restoring a functional, albeit unfocused, level of vision to a previously blind patient.
While Al-Zahrawi was engineering tools in Spain, other practitioners in the Islamic world were making anatomical discoveries that directly challenged foundational medical texts. A prominent example is the physician Ibn al-Nafis, who lived from 1213 to 1288.
He made a massive breakthrough regarding the cardiovascular system. Ibn al-Nafis discovered and accurately documented the pulmonary circulation of the blood.
This was a direct, explicit correction of Galen.
Yes. For centuries, Galenic theory held that blood was created in the liver, traveled to the right side of the heart, and then mysteriously seeped through invisible pores in the septum.
The muscular wall dividing the heart.
Right, to reach the left side.
But Ibn al-Nafis proved those invisible pores didn't exist.
He observed a thickness and impermeability of the cardiac septum and deduced that the blood had to take an alternate route. He correctly described that deoxygenated blood travels from the right ventricle of the heart out through the pulmonary artery to the lungs.
In the lungs, it mixes with air, becomes oxygenated, and then returns via the pulmonary vein to the left atrium of the heart to be pumped to the body.
He mapped this entire cardiovascular transit centuries before the European physician William Harvey published his findings.
Similarly, another physician named Ibn al-Quwaf expanded on this by describing the microscopic connections between the arteries and the veins, what we now call capillaries.
He also accurately described the function of the cardiac valves in ensuring unidirectional blood flow, and they were deducing these intricate anatomical realities through intense clinical observation, logic, and surgical experience, entirely without the aid of a microscope.
It's important to trace where some of this physical surgical confidence originated. The Greek medical tradition, while intellectually rigorous, was largely theoretical and text-based.
Right. Islamic surgeons, however, were heavily influenced by the translation of the Indian Sushruta Samhita, which provided a robust, highly practical tradition of physical interventions, anatomical manipulation, and surgical tool usage.
By synthesizing the Greek anatomical theory with Indian surgical practice, they forged a highly effective discipline.
Exactly.
So we have established a medical landscape where physicians are conducting detailed clinical trials, mapping pulse rhythms to poetic meters, prescribing specific dietary regimens, and executing deep internal surgeries while managing anesthesia.
You cannot execute this level of complex medical intervention safely in a patient's home or a dusty tent. You require a massive, highly controlled sanitary environment.
And that sheer necessity birthed the institution we discussed at the very beginning of this deep dive, the Bimaristan.
The term Bimaristan translates from Persian simply as house of the sick. But it's crucial to differentiate these institutions from earlier historical models. These were not hospices designed merely to house the dying.
Nor were they temples focused on miraculous healing.
No, they were highly structured, deeply secular centers of empirical medical treatment.
The timeline of their development across the Islamic empires is incredibly rapid. The first documented general hospital appears in Baghdad in 805, shortly after the translation movement began to accelerate.
By 1154, you have the establishment of the famous Nuri Hospital in Damascus.
And by 1284, the Al-Mansuri Hospital is constructed in Cairo. The historical records indicate the Al-Mansuri had the infrastructure and capacity to treat up to 8,000 patients simultaneously.
The massive scale is notable, but the operational organization is what truly defines them. The bimaristans were rigorously structured. First, they were strictly segregated by sex, ensuring patient privacy and maintaining cultural modesty.
Second, they were divided into highly specialized wards. A patient entering the bimaristan would be evaluated in a triage area and then assigned to a specific ward corresponding to their pathology.
You wouldn't just be placed in a large room with everyone else. If you had a fever, you went to the internal medicine ward. If you had a fractured femur, you went to the orthopedics ward.
They had dedicated surgical theaters, ophthalmology wards for eye diseases, and crucially, they had dedicated wards for contagious diseases, physically isolating infectious patients to prevent outbreaks, effectively utilizing early quarantine protocols.
The standards of daily care detailed in the administrative records are highly specific. When a patient was admitted, their personal street clothes were removed and safely stored.
They were required to bathe and wear clean, hospital-issued linens to prevent the introduction of outside pathogens.
The architectural design of the wards featured advanced plumbing with continuous running water, large windows positioned to maximize sunlight, and lush internal courtyards to facilitate the flow of fresh air.
And there were strict daily sanitary inspections conducted by hospital administrators to ensure hygiene protocols were followed.
Furthermore, these bimaristans served as the premier educational institutions of the era. They functioned explicitly as teaching hospitals, designed to train the next generation of medical professionals.
Medical students would physically shadow senior physicians on their daily clinical rounds. The students were required to take detailed notes on the patient's symptoms, record the prescribed treatments, and monitor the outcomes.
They also attended large, didactic lectures delivered by the chief physicians in the hospital's dedicated libraries and lecture halls.
This massive influx of students brings up the critical issue of regulation. Because they were training hundreds of practitioners, the state needed a mechanism to ensure quality control and prevent malpractice.
The records document a highly significant administrative event in Baghdad in the year 931. Following the tragic death of a patient that was directly attributed to a physician's error, Caliph al-Muqtadir intervened directly.
He mandated a formal, state-run licensing system.
It was a massive formalization of professional accountability. The Caliph appointed a chief medical officer who systematically examined over 860 practicing physicians in Baghdad.
They had to demonstrate theoretical knowledge and practical competency. Only those who passed the rigorous exams were issued a license to continue practicing medicine in the city.
And this formalized bimaristan network was not restricted solely to the major metropolitan centers. The state recognized the need to project medical infrastructure outward.
The records detail the deployment of mobile medical units, essentially traveling dispensaries and clinics equipped with surgical tools, pharmaceutical compounding ingredients, and licensed doctors.
These units traveled to remote rural areas, provided immediate triage during epidemics, and accompanied the military on extended campaigns.
The logistics were immense.
Yeah.
Some of these mobile hospitals were so massive and well-equipped that they required a train of 40 camels just to transport the equipment and staff.
That's a huge operation.
I have to pause here and ask about the underlying economics of this massive infrastructure. When we look at sprawling hospital complexes today, they are driven by complex billing systems, vast insurance networks, and massive administrative overhead.
Right.
How did a medieval society, operating a millennium ago, economically sustain these health centers? How did they manage to provide high-level surgical care, daily pharmaceutical compounding, and room and board for thousands of patients, completely free of charge, regardless of the patient's wealth or religion?
The economic engine that powered the bimaristans, rendering them completely free for patients, was a highly specific Islamic legal structure known as the waqf system. A waqf is a permanent, inalienable, charitable endowment.
Let's break down the mechanics of how that actually works.
A wealthy individual, a high-ranking official, or the ruling caliph would legally endow massive physical revenue-generating assets to the hospital. This was not a one-time donation of gold. They would endow vast tracts of agricultural land, busy commercial shops in the urban bazaars, or critical infrastructure like water mills.
So the hospital was functioning as a massive real estate holding company.
Exactly. The hospital owned those assets in perpetuity. The agricultural yields, the commercial rent from the shops, and the fees from the water mills went directly and exclusively to fund the hospital's operating budget.
This meant the hospital wasn't relying on a fluctuating yearly government budget that could be cut during a war.
Nor did it rely on the unpredictable charity of donors.
The real estate revenues permanently insulated the hospital from political upheavals and economic instability.
And the foundational legal documents establishing the WAC were explicit. The legal charters mandated, in writing, that the hospital must serve all people. They legally codified that no patient could ever be turned away due to an inability to pay, their social status, or their religious affiliation.
The ethical dimensions outlined in these WAF documents are really striking. They stipulate that a patient could not be discharged from the Bimaristan until they were fully, demonstrably healed, often proven by their ability to consume a specific quantity of solid food.
And as we mentioned at the start, the WAF funds were often used to provide a monetary stipend to poor patients upon discharge, ensuring they could rest at home rather than immediately returning to grueling manual labor while still in a vulnerable state of recovery.
It reflects a societal commitment to public health that views recovery not just as a physiological event, but as a holistic process that requires both physical healing and temporary economic stability.
Now, to operate these massive free hospitals with specialized wards running 24 hours a day, you require a vast, highly trained labor force.
The historical records reveal that the practice of medicine during this era was remarkably diverse, actively utilizing the skills of women and non-Muslim minorities.
The deep integration of non-Muslims, formerly recognized as dhimmis, was foundational to the medical system. We previously detailed how Hunayn ibn Ishaq, an historian Christian, led the translation movement.
But that integration extended far beyond linguistic scholarship into clinical practice and high-level hospital administration.
Syriac and Nestorian Christians were heavily represented in the medical elite. A prime example is the Bektishu family. They were a prominent family of Nestorian Christian physicians from Gondeshapur who relocated to Baghdad.
They were so highly respected that they produced multiple generations of physicians who served as the exclusive personal doctors to several Abbasid caliphs over the course of centuries.
Jewish physicians also attained incredibly high status, particularly in the western regions of the empire, such as Al-Andalus or Islamic Spain. A prominent historical figure is Hazrat ibn Shaprut, operating in the 10th century.
He was not just an elite court physician in Cordoba. His medical acumen granted him such influence that he simultaneously served as a highly trusted diplomat and political advisor for the caliphate.
It demonstrates the vertical mobility available to minority medical professionals within the social hierarchy. And we must examine the critical, formally recognized role that women played within this medical ecosystem.
The historical records highlight figures like Rufayda al-Islamiyya from the 7th century, who was widely recognized as the first formally trained Islamic nurse.
During military conflicts, she didn't merely act as a caregiver. She organized and managed a dedicated medical tent to triage and treat wounded soldiers on the battlefield, and she systematically trained other women in clinical wound care and hygiene.
The presence of women was not relegated to wartime emergencies. It was structurally integrated into the daily healthcare system of the empire. Midwives, known as kabila or deyas, were highly trained professionals who operated largely independently.
They handled routine childbirth, but they were also skilled in managing complex, life-threatening obstetrical emergencies like breech presentations, and they provided extensive prenatal and postnatal clinical advice.
Furthermore, because the massive Bimaristans were strictly segregated by sex, the dedicated women's wards required a massive female staff. These wards were staffed entirely by professional female nurses, known as muqawimat.
This staffing structure was designed to adhere strictly to cultural and religious standards of modesty, known as haya.
This is a fascinating historical dynamic. The strict Islamic laws and cultural norms surrounding gender segregation actually necessitated the creation of a massive, highly educated class of female medical professionals.
If a male doctor cannot routinely examine a female patient, society is forced to formally train women in complex medical procedures to ensure half the population receives comprehensive health care.
It was an unintended but major consequence of the social structure. The records detail highly specific treatments developed and administered within these female wards. Practitioners utilized various pharmacological contraceptives, such as tampons saturated in honey paste or cedar oil, to create chemical and physical barriers.
They prescribed intricate fertility regimens, and female practitioners performed physical surgical interventions, utilizing tools like the specialized vaginal speculum designed by Al-Zahrawi to perform procedures such as hymenotomies.
But I want to challenge this narrative slightly. We are describing a system where Nestorian Christians, Jewish diplomats, and highly trained Muslim men and women are all working in a highly functional, integrated medical infrastructure.
Right.
Sounds very utopian. But were there limits to this diversity? Did this tolerance hold universally?
That is an essential nuance to address. While broad tolerance and a reliance on diverse expertise was the general operational norm, particularly during the height of the Abbasid Golden Age and in early Andalusia, it was not a universal or permanent state of affairs.
There were specific historical periods marked by severe Orthodox pushback and political contraction.
A clear example is under the Almohad dynasty in the 12th century, ruling over North Africa and Islamic Spain, or during certain periods of Mamluk rule in Egypt.
During these periods of religious and political tightening, non-Muslim practitioners faced severe marginalization.
They were frequently restricted from holding high-ranking administrative offices in the Baimaristans or serving as chief court physicians unless they formally converted to Islam.
And regarding women in medicine,
While women practiced extensively and independently in the female wards and as highly skilled midwives, access to formal, elite medical theory training in the madrasas and the prestigious public titles of chief physician were almost entirely restricted to men.
the women who did attain high levels of formal theoretical medical education were usually from elite privileged circles.
Such as the daughters of established male court physicians who were trained privately in their homes rather than in the public academies.
So it was a highly diverse and functional workforce driven by immense practical necessity, but it still operated entirely within the strict hierarchical and patriarchal confines of the medieval era.
Exactly.
Now, as these diverse practitioners across these vast empires spent centuries constantly experimenting with new treatments, documenting clinical trials, and refining ancient theories, they inevitably pushed the boundaries of drug creation.
This leads us directly to the birth of modern pharmacology and a scientific legacy that would eventually cross the Mediterranean and fundamentally reshape Europe.
The pharmacological advances achieved in the Islamic world were huge because they moved the discipline of drug compounding from a practice of simple herbalism and folklore into a mathematically quantified, rigorous physical science.
A prime example of this epistemological shift is the work of Al-Kindi in the 9th century.
Al-Kindi authored a complex treatise called De Gradibus, and he did something entirely novel. He applied advanced mathematics to the compounding of medicine.
He attempted to quantify the exact potency of a compound drug by applying mathematical scales and geometric progressions to its ingredients.
He was trying to eliminate the guesswork. He utilized mathematics to calculate the exact dosage required to shift a patient's humoral balance back to center, factoring in specific variables like the patient's exact age, their body weight, and the calculated severity of their illness.
It was a formal attempt to introduce absolute calculable precision into the prescribing of medications.
Later, in the 13th century, we see the culmination of botanical pharmacology in the extensive work of Ibn al-Battar, an Andalusian botanist.
Ibn al-Battar authored the Compendium of Simple Drugs and Foods. In this massive text, he cataloged over 1,400 different plants, animal products, and minerals used for medicinal purposes.
But what makes his work scientifically significant is not just the sheer volume of entries. It is his strict insistence on empirical testing.
He didn't just copy down old folklore about a plant's supposed properties. He traveled extensively, located the plants, administered them, and evaluated their physical effects through rigorous observation.
He explicitly prioritized tested, documented efficacy over traditional superstition.
And the physical preparation of these drugs became an advanced science in itself. Islamic pharmacists utilize complex chemical engineering techniques to extract the active medicinal ingredients from raw plants and minerals, creating highly precise, concentrated liquid remedies.
Let's talk about the mechanics of those chemical techniques, specifically distillation and sublimation. How did a medieval pharmacist actually extract an essential oil or pure alcohol?
They utilized a specialized piece of laboratory glass or metalware known as the alembic, or alembic in Arabic. The apparatus consists of two vessels connected by a tube.
To distill alcohol for surgical antisepsis, for example, You place a fermented liquid mixture in the lower vessel and apply a highly controlled heat source beneath it.
Because different liquids boil at different temperatures.
Exactly. Because alcohol vaporizes at a lower temperature than water, the heat causes the alcohol to turn into a vapor first. This vapor rises into the curved neck of the alembic, travels down the connecting tube, which is kept cool, and condenses back into a liquid state in the receiving vessel.
Through this mechanical process of controlled heating and cooling, they extracted pure medicinal alcohols and highly concentrated essential oils, leaving the impurities behind in the boiling vessel.
The complexity of this compounding process led to the establishment of the pharmacy as a distinct, specialized wing of the hospital, staffed by licensed pharmacists, completely separate from the physicians who diagnose the patients and prescribe the drugs.
It was the birth of the modern pharmaceutical industry.
All of this meticulously documented knowledge, the mathematical pharmacology, the surgical tools of Al-Zahrawi, the massive encyclopedias of Avicenna and Al-Razi, the clinical trial data, eventually made its massive transfer to Europe.
The historical records refer to the 12th century as the Golden Age of translation for Europe. The geopolitical borders were porous. Cities like Toledo in Spain, which had recently been captured by Christian forces but still housed vast Arabic libraries, and regions like Sicily, which had significant, continuous contact with the Islamic world, became major intellectual hubs.
European scholars flocked to these centers for the express purpose of translating these Arabic scientific texts into Latin.
A central figure in this movement was a scholar named Gerard of Cremona. He relocated to Toledo and dedicated his life to this effort.
He translated dozens of texts, but most crucially, he translated Avicenna's million-word canon of medicine and Al-Zahrawi's illustrated surgical manual, the Kitab al-Tasrif, into Latin.
And the impact of these translations on Europe cannot be overstated. These texts didn't just enter private libraries, they became the absolute foundational curriculum for the earliest European medical universities, institutions like Salerno, Padua, and Montpellier.
Avicenna's canon was utilized as the primary authoritative medical textbook in European university classrooms continuously until the 17th century.
It is absolutely crucial to understand the dynamic of this transmission. The Islamic world didn't merely act as a passive, dusty library that held on to ancient Greek texts during the European Dark Ages, only to hand them back untouched centuries later.
They aggressively dismantled the ancient texts, tested them, corrected them, and actively upgraded the knowledge.
The historical transmission is frequently misunderstood in that way.
It's like Europe handed the Islamic world a basic wooden abacus in the 7th century. And centuries later, in the 12th century, the Islamic world handed Europe back a complex, highly engineered mechanical calculator.
When Europe received this information in Toledo, it didn't just get Galen back. It got Galen heavily annotated, explicitly corrected by Al-Razi's empirical data, attached to hundreds of years of new clinical trial protocols, accompanied by highly engineered surgical tools, and backed by mathematically quantified pharmacology.
The most vital export from the Islamic world to Europe wasn't a specific botanical drug, a specific surgical tool, or even a specific anatomical discovery.
The most vital export was the underlying epistemological methodology.
They transmitted the rigorous concept of evidence-based practice, the necessity of clinical observation, the mechanics of the clinical trial, and the process of systematic peer review.
It was this rigorous empirical methodology that directly sparked the European medical renaissance.
Let's bring all this together. We started this deep dive by looking at a peasant entering a 9th century Bimaristan in Baghdad, trying to understand how such a sophisticated, free institution could possibly exist a millennium ago.
What we have uncovered is a civilization that aggressively gathered the disparate medical traditions of Greece, Persia, and India and standardized them through a massive state-funded translation movement.
We've seen how skeptical practitioners like Al-Razi and Avicenna used empirical observation in clinical trials to test and upgrade that ancient knowledge, shifting medicine from philosophy to science.
We examine Al-Zahrawi engineering the material tools of modern surgery and Ibn al-Nafis charting the flow of blood.
We detailed how the WAF system economically insulated massive hospitals, allowing them to provide free, specialized care utilizing a diverse, highly trained workforce.
Ultimately, we traced how this upgraded, meticulously documented medical science was transmitted to Europe, laying the very foundations of modern global healthcare.
If we look back at those massive, endowment-funded Bimaristans from a millennium ago, providing free, advanced medical care to all citizens regardless of their status, wealth, or religion, it raises a historical question for you to mull over. Today, we often view accessible universal healthcare as a distinctly modern Western political invention.
But looking at the rigorous ethical and economic standards permanently set in the hospitals of Damascus and Baghdad centuries ago, we have to ask, have we truly advanced the ethics of public health administration, or are we just catching up to a standard that was already established and functioning a millennium ago?
Thank you for listening. History Maps. Learn history visually.